This patient responded to alectinib, which you expect 70 to 80% patients to do, but the duration of response or the progression-free survival was much shorter than 34 months. It was 9 months. So I think this patient did not do as well on alectinib. Resistance to these drugs is what frustrates us all because eventually resistance develops. And we are trying to keep these patients from getting to chemotherapy by changing drugs. But it's not a simple story like EGFR, where 50 to 60% of patients will have T790M mutation, and then we had a drug osimertinib approved for that, and now osimertinib is first line. Here there's a whole potpourri of ALK alterations. It's not just one major mutations, lots of mutations, and besides those mutations, there are other mechanisms of resistance, of amplifications or bypass pathway activation, etc. So I think it's imperative to do a biopsy, or at least a liquid biopsy, which would be a blood test, to see what type of resistance mechanism has emerged. And there are different mechanisms. When you see patients progressing on crizotinib, that's a different spectrum than if patients progress on a second generation ALK inhibitor. And one of the problematic mutations after progression on second line can be a 1202R mutation, which is covered by brigatinib at the dose of 180, and also covered by lorlatinib, the fifth approval that we got in subsequent line therapy. But it's not covered for alectinib, for example. So one has to be cognizant of what mutation and which drugs cover it, which drugs don't. In terms of what we recommend after progression is biopsy, at least liquid biopsy, and if that's negative, not to assume that there is no known mechanism, then go to a tissue biopsy in every case where possible.